Hi friends, in this series of ECG Basics, today I will talk about ST segment. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. ST segment. It is a flat isoelectric section of the ECG between the end of the S wave, that is the J point, and the beginning of the T wave. The ST segment represents the interval between ventricular depolarization and repolarization. The most important cause of ST segment abnormality, that is elevation or depression, is myocardial ischemia or infarction. The causes of ST segment elevation are acute myocardial infarction, coronary vasospasm, that is Printzmetal angina, pericarditis, benign early repolarization, left bundle branch block, left ventricular hypertrophy, ventricular aneurysm, Brugada syndrome, ventricular paced rhythm, raised intracranial pressure, and Takotsubo Cardiomyopathy. The morphology of the elevated ST segment. Myocardial infarction. The acute ST elevation MI may produce ST elevation with either concave, convex, or obliquely straight morphology. So, in other conditions like pericarditis, benign early repolarization, left bundle branch block, LV aneurysm, Brugada, we have different morphologies which I will be discussing in my subsequent slides. The pattern of ST elevation. In acute ST elevation MI, the ST segment elevation and Q wave formation in the contiguous leads. Follow the links above to find out more about the different ST elevation pattern. For example, if we get ST elevation in V1, V2, we call it as a half septal. The anterior is V3 to V4. Lateral is lead 1 AVL V5 to V6. Inferior leads are 2, 3 AVF. Right ventricular is V1 and V4R. Posterior ST elevation is seen in V7 to V9, and there is usually reciprocal ST depression in the electrically opposite leads. For example, ST elevation in the high lateral leads, that is lead 1 AVL, typically produces the reciprocal ST depression in lead 3. In Printzmetal angina, that is coronary vasospasm, we see a pattern of ST elevation that is very similar to acute ST elevation MI, that is, there is localized ST elevation with reciprocal ST depression occurring during the episode of chest pain. However, unlike the acute ST elevation MI, the ECG changes are usually transient. They are reversible with vasodilators, and they are not usually associated with myocardial necrosis. It may be impossible to differentiate these two conditions based on the ECG alone. In pericarditis, we get widespread concave, that is saddleback ST segment elevation with PR segment depression in multiple leads, typically involving lead 1, 2, 3, AVF, AVL, and V2 to V6. We get concave saddleback ST elevation in lead 1, 2, 3, AVF, V5 to V6 with depressed PR segment. There is reciprocal ST depression and PRE elevation in lead AVR and V1. So the spodic sign, which was first described by David H. Spodek in 1974 as a downward slope TP segment with specificity for acute pericarditis. Spodek sign I have already discussed in one of my lecture in ECG. Coming to the benign early repolarization, it causes mild ST elevation with a tall T wave mainly in the precordial leads. Benign early repolarization is a normal variant and it is commonly seen in young healthy patients, and there is often notching of the J point, and we call it as a fish hook pattern. The ST changes may be more prominent at the slower heart rates and they disappear in the presence of tachycardia. In this ECG, we can see there is slight concave ST elevation in the pericardial and the inferior leads with the notching of the J point, that is the fish hook pattern. In left bundle branch block, the ST segments and the T wave, they show appropriate discordance, that is, they are directed opposite to the main vector of the QRS complex. This produces ST elevation and upright T waves in leads with negative QRS complexes while producing ST depression and T wave inversion in the leads with positive QRS complexes, that is dominant R waves. Note in this ECG the ST elevation in leads with deep S waves most apparent in lead V1 to V3, and also note the ST depression in leads with tall R waves most prominent in lead 1 and AVL. In left ventricular hypertrophy, the left ventricular hypertrophy causes a similar pattern of repolarization abnormalities as left bundle branch block with ST elevation in leads with S wave usually V1 to V3 and ST depression or T wave inversion in the leads with tall R waves in lead 1 AVL V5 to V6. We also see left axis deviation deep S wave with ST elevation in V1 to V3, ST depression and T wave inversion in the later leads, that is V5 to V6. In ventricular aneurysm, the ECG changes show residual ST elevation and deep Q waves in patients with previous myocardial infarction. It is associated with extensive myocardial damage and paradoxical movement of the left ventricle wall during the systole. And there is ST elevation with deep Q waves and inverted T waves in V1 to V3. This pattern suggests the presence of left ventricular aneurysm due to the prior anteroseptal MI. Brugada syndrome, it is inherited channelopathy, a disease of myocardial sodium channel that leads to paroxysmal ventricular arrhythmias and sudden cardiac death in young patients. The telltale sign in the resting ECG is the Brugada sign, that is ST elevation and partial right bundle branch block in V1 to V2 with COVID morphology. There is ST elevation and partial RBB in V1 to V2 with COVID morphology as we see in this ECG, and this is called Brugada sign. Ventricular paced rhythm, that is with pacing wire in the right ventricle, causes ST segment abnormalities identical to that seen in left bundle branch block, and there is appropriate discordance with the ST segment and T wave directed opposite to the main vector of the QRS complex. In the patients with raised intracranial pressure, that is due to intracranial hemorrhage or traumatic brain injury, we may see ST elevation or depression that may simulate the myocardial ischemia or the pericarditis, and more commonly the raised ICP is associated with widespread deep T wave inversion, that is cerebral T waves. In this ECG we can see widespread ST elevation with concave that is pericarditis like morphology in patients with severe traumatic brain injury. Patients with Takotsubo Cardiomyopathy, we see ST elevation MI mimic producing ischemic chest pain. ECG changes are ECG changes can be seen. There uh, may or may not be elevated cardiac enzyme with characteristic regional wall motion abnormalities on echocardiography. In ECG, we may see ST elevation or T wave inversion, and these patients may have moderate troponin rise. The less common causes of ST segment elevation are pulmonary embolism, acute carpulmonale, usually seen in lead 3, acute aortic dissection, and classically causing inferior ST elevation MI due to right coronary artery occlusion or dissection. Patients with hyperkalemia, sodium channel blocking drugs like uh, that is secondary to QRS widening, J wave seen in hypothermia, hypercalcemia, following electrical cardioversion. The other conditions like cardiac tumor, myocarditis, pancreas, or gallbladder disease, they may at times show uh, ST segment elevation. This is the ECG which is showing transient ST elevation after DC cardioversion from ventricular fibrillation. We can see J waves in hypothermia simulating the ST elevations. The causes of ST depression are myocardial ischemia, non-ST elevation MI, reciprocal changes in the ST elevation MI, posterior MI, digoxin effects, hypokalemia, supraventricular tachycardia, right bundle branch blocks, right ventricular hypertrophy, left bundle branch block, left ventricular hypertrophy, ventricular paced rhythm. The morphology of ST depression, it can be either upsloping, downsloping, or horizontal. Horizontal or downsloping ST depression that is more than 0.5 mm at the J point in more than or equal to two contiguous leads indicates the myocardial ischemia according to 2007 task force criteria. Upsloping ST depression in precardial leads with prominent D winter T wave is highly specific for occlusion of the left anterior descending artery. Reciprocal changes has a morphology that resembles a upside down ST elevation, and it is seen in leads electrically opposite to the site of infarction. Posterior MI manifests as a horizontal ST depression in V1 to V3, and it is associated with upright T waves and tall R waves. In this ECG, we can see the upsloping ST segment depression, downsloping ST segment depression, and horizontal ST segment depression. So these are the uh, ST segment morphologies in various types of myocardial ischemias. So, in myocardial ischemia, ST depression due to subendocardial ischemia may be present in a variable number of leads and with variable morphology. It is often most prominent in the left precordial leads, that is V4 to V6, plus leads 1, 2, and AVL. Widespread ST depression with ST elevation in AVR is seen in the left main coronary artery occlusion and severe triple vessel disease. ST depression localized to the inferior or the high lateral leads is more likely to represent the reciprocal changes than the subendocardial ischemia. The corresponding ST elevation may be subtle and difficult to see but should be sought, and this concept is discussed further in details. The reciprocal changes. The ST elevation during acute ST elevation MI is associated with simultaneous ST depression in electrically opposite leads. The inferior ST elevation MI produces the reciprocal ST depression in lead AVL, or it may be present or may be absent in lead 1. Lateral or anteroseptal ST elevation MI produces reciprocal ST depression in lead 3 and AVF, and at times in lead 2. The reciprocal ST depression in V1 to V3 occurs with posterior infarction as seen in ECGs given there. Posterior myocardial infarction. The acute posterior ST elevation MI causes ST depression in the anterior leads, that is V1 to V3, along with dominant R waves, that is equivalent Q wave equivalent, and upright T waves, and there is ST elevation in the posterior leads, that is V7 to V9. The deep inter T waves, it is a pattern of upsloping ST depression with symmetrically peaked T waves in the precordial leads, and it is considered to be ST elevation equivalent, and it is highly specific for acute occlusion of the left anterior descending artery. The digoxin effect. The patients receiving digoxin as a treatment may show downsloping ST depression with a sagging morphology, which represents or reminiscent of the Salvador-Dali's moustache. Patients with hypokalemia may show widespread downsloping ST depression with T wave flattening or inversion, prominent U waves, and a prolonged QU interval. The patients with right ventricular hypertrophy may show ST depression and T wave inversion in the right precordial leads, that is V1 to V3. Similarly, the patients with right ventral branch block may produce a similar pattern of repolarization abnormalities that to right ventricular hypertrophy with ST depression and T wave inversion in V1 to V3. Patients with supraventricular tachycardia, there we can see widespread horizontal ST depression, most prominent in the left precordial leads, that is V4 to V6. This rate related ST depression does not necessarily indicate the presence of myocardial ischemia, provided that it resolves with the treatment. I have given the reference from which I have taken these ECG and other explanations. If you really want to do something, you will find a way, and if you don't, you will find an excuse. It was said by Dr. Frederick Banting. With this, I conclude my today's topic. Thank you. Keep learning.